Hi.
Shiva, we see you.
Okay. Shaq, it was nice to have been in the conference hall for the last 2 days with all of you. You have been doing an excellent job. And in order to match the session for today, we have got 2 right heart interventions for this session. My colleague, Dr. Ronak, will give the clinical case scenario. Dr. Ronak.
Good morning, everyone. I'm Dr. Ronak. I'll take you through the first case for the transmission. Baby SR, 9-month-old girl child, born near term, born small for gestational age with a birth weight of 1.7 kilograms, with a precordial murmur identified in early infancy, and then growth failure and developmental delay continuing through. Currently weighs 5.7 kilograms, 61 centimeter length, has phenotypic features of Williams syndrome, heart rate of 120 per minute with normal pulses, no cyanosis, grade 3/6 ejection systolic murmur at the left upper sternal border. X-ray showed RV apex. ECG showed right ventricular forces. Echocardiography showing right ventricular hypertrophy. No significant TR. Parasternal short axis view showing the branch pulmonary arteries, showing a diffuse long segment stenosis of the right pulmonary artery and a membranous stenosis of the LPA origin. The peak gradient across the RPA was 90 millimeters, whereas across the LPA was 45 millimeters mercury. A CT pulmonary angiogram was done to delineate the pulmonary anatomy. So the diagnosis is severe long segment RPA stenosis, discrete membranous LPA origin stenosis, adequate sized bilateral hilar PS. The plan is RPA stent angioplasty and LPA balloon angioplasty. Thank you.
Okay, thank you.
Hi, Shaq. Now I have with me staff nurse Shari, my colleague Dr. Uma Mageshwar.
Hello.
And for imaging, Dr. Aravind, anesthetist and intensivist Dr. Uday, and a team of people here. We started quite early in the day. We started our lab at 5 o'clock today, and it is now almost just past 6 now. And so Dr. Shaq, this is Williams syndrome with elevated RV pressures. No supravalvar aortic
stenosis. Thank all the staff for getting up so early in the morning.
Thank you.
It's very difficult to get up in the morning, especially for me, so I'm really impressed that they got there at 5 o'clock to start.
Yeah.
Okay, so let's see the pressures and then...
yeah, the pressures were right atrial pressure of 14 millimeters. Right ventricle was 80 when the aortic pressure is, show the aortic pressure live, when the aortic pressure was around 85, 86. And the pulmonary artery, the distal right pulmonary artery was 20. The distal left pulmonary artery was 30. There was 60 gradient at the right and 50 at the left. I will show you the right pulmonary artery angiography. We have bilateral venous access. Both of them are 5 French. So this is the flexor sheath that has been inserted into the right ventricle, and Judkins right introduced into the right pulmonary artery beyond the stenosis. We are checking for the peripheral pulmonary artery arborization because some of these patients may have a very distal PA stenosis, and then we may not get a great result following the ballooning of the proximal mediastinal PA. So this is a check of the post-hilar pulmonary arteries, which are good. The levo phase shows reasonably wide open supravalvar aorta. Next picture. So this was the second image. So here, freeze the image when the RPA is seen. Yeah, get back. Yeah, so this is the it's a diffuse long segment right pulmonary artery narrowing. Next frame. Next frame. Yeah, keep moving. There was one frame where previous. Yeah. Just adjust the frame. Next, next, next. Yeah, Shaq, you are able to see the images?
Yes, we do, yeah.
Yeah, so what we are...
5.7, 3.3.
Yeah, the length of the narrowing before the hilar bifurcation, it seems to be somewhere around 18 millimeters.
And the left pulmonary artery,
Yeah.
have you got any pictures of that?
Yeah, left, next picture, next. So we crossed into the left and next, freeze, go back. Go back, yeah, just right. So the left here was measuring around 3 at the ostia and somewhere around 9 at the hilum.
Okay, so let me just ask a few people what to do here. So Dietmar, you haven't said anything at all. You've been very quiet. Challenging anatomy, easy thing to deal with?
Good morning, Shiva.
Hi.
I love your presentation at 5 o'clock in the morning.
Hi, Dietmar.
It's a very nice case to present. For example, the difference between the left and the right. The left stenosis has a post-stenotic dilatation. I love it to see. So you have a good impact to improve by ballooning only, maybe this part. The right side is a dysplasia of the complete right pulmonary artery. I would avoid in the Williams syndrome to put a stent in. It makes maybe looking nice, but you have a 100%, 101% that you will have an instant whatever fibrosis later on, or hypoplasia, maybe in a half in 1 year. So sorry, you are speaking very well German. I don't speak good English. So my question is really why, or I would reduce my intervention on dilatation and would avoid to stand it to this time because the patient has a right ventricular pressure of half.
So
of
follow-on question. Don't go away yet. Balloon dilation alone, low pressure, high pressure, cutting balloon, which?
That's additional good. I would start with the left side because you have a post-stenotic dilatation.
Yeah.
They have a better impact for ballooning, and would use here a high pressure balloon at first, and we'll see what happens.
And
The
then-
right side,
Yeah.
the right side is a problem. You can dilate it, but I think the most important is that he will not lose the right pulmonary artery over time.
Okay.
But I think the Williams will be persistent, this situation,
Yeah.
even in 1 year.
Okay, Zahid? When you stop fighting. Yeah.
We never fight.
Punch him harder now, yeah, punch him harder.
8 into 2.
Okay, Zahid.
First of all, Shiva, is this patient is symptomatic for the right side, or?
There was a
How do you mean symptomatic from the right?
It's a Williams syndrome with an elevated right ventricular systolic pressure. The child is significantly failing to thrive, possibly due to Williams syndrome, maybe due to the elevated RV pressures. Very often, right-sided obstructive lesions do not create so much of systemic venous congestion unless they go into failing right ventricle. This patient has got an RA mean pressure of 14.
It's my turn to talk now. Hang on. You gotta let me talk. Finish my question before you start answering. When I was saying natural history for Williams syndrome patients usually is that their per HPA stenosis and their pulmonary valve stenosis actually gets better over time.
Gets what?
Gets better.
Better, yeah.
Better over time, and
Okay.
if you intervene too much, they actually get worse.
Keep it ready.
A lot of time you can swallow higher pressures and follow them. They may get better. I mean, I agree with Dietmar, the left PA, that tiny stenosis, balloonable, but
Yeah.
there could be a risk of causing pulmonary edema and all that stuff
Mario?
on the contralateral side.
Mario, microphone.
Yeah, well, I agree with the consideration done by Dietmar and Zaid, and I think it's rather unpredictable what's going on with ballooning, but that would be interesting to see that. And in fact, for the right PA, probably the first attempt is the balloon fails. Cutting balloons could be an option.
Okay, Kevin,
Freeze when the
very
PA is
quickly,
seen
and
better.
then we'll go back to Shiva.
I mean, for the Williams, I think you would need more than systemic right ventricular pressure to want to intervene. You sort of want super systemic and maybe good evidence that the RV is in trouble and suffering. The failure to thrive is likely to be the Williams.
Change this color to
but
yellow,
not
the red to
right,
yellow.
Unless he has definite right heart failure requiring diuretic. So if you were going to do it, I guess plain balloon on the left to start with and cutting balloon on the right.
Yeah. Okay. Adam, very quickly.
Yeah, I think in Williams syndrome, generally, you want to reduce your intervention as far as possible because they are quite touchy and
Yeah. Okay.
unpredictable.
All right. Shiva, so opinion at this end is it's a horrible disease. Some of the Williams syndrome branch pulmonary artery stenoses get better on their own. Others, you try and avoid stenting as much as possible.
Yeah.
So fairly sort of different message to what you were saying. But you tell us your progress and what your plans are.
So the consensus from the hall is we should try a balloon dilatation. Hello. Okay, show the next picture.
Yes, sorry, Shiva.
Can you repeat that, Siva?
No, so what we did was we balloon dilated. I'll show you now the post balloon dilated picture. Next. Next. So this is a balloon dilatation with 4 atmospheres of a 6 millimeter balloon. So I'll show you the post pulmonary artery angiography. Next. Freeze it. Freeze. Yeah. What you are seeing, the pressures now is post balloon dilatation, and we are actually there is a streaming of contrast here, so we are not able to get a good picture. I will try to give you a direct injection from the sheath.
So this was which type of balloon was it?
Taishak, it's your balloon. I saw yesterday your balloon used for middle aortic syndrome, Takayasu. So we are using your balloon for a Williams as well. I have a high pressure Mustang balloon as well. Here, since the balloon totally opened, freeze it.
See, my impression is that there is a little bit of improvement in that RPA, and I wouldn't expect massive improvement, but I'd probably accept any improvement in these without the need for stenting.
Okay.
Because stenting creates a different disease which is difficult to treat.
Okay. So
I would be happy. And also your RV pressure is subsystemic as opposed to what it was before.
what you are seeing is live, the pressures. You have a pressure of 66 on the right ventricle and 77 on the aorta.
So I would leave the RPA and then focus on the LPA.
Okay. Now
So what are you going to do now?
Since we have gone with a Taishak balloon, I am going with a high pressure balloon right now. So this high pressure balloon is a Mustang. Yeah, Boston Scientific.
Yeah. Now your other catheter's probably getting in the way, isn't it?
Yeah, and
what's that, Siva?
Shiva, let us just go to Ho Chi Minh and join Tin because he's ready for a very complex case. We'll come back to you after that.
Sure.
Yeah?
Okay.
Okay, let's go to Tin. Hello, Shiva.
Hello, Siva.
Yeah, hi. So is that Shaq? Yeah, is that Shaq? Go back to the previous. Go to the Shaq or Nick, who is that?
Yep. Go ahead, Shiva.
Shaq, see, what we did was, we did, I'll just show you. Show two before. One more before. Okay. This was the previous. This was following the Taishak balloon with 4 atmospheres, and second one was next.
You did a very good job.
So this is
Taishak did a very good job in this.
yeah, and
Mansoor.
and now this is a Mustang Boston Scientific. Next picture.
Yeah.
Next picture. Freeze it.
So what pressure did you go up to, Siva, with that Mustang?
The Mustang, we went up to around 12 to 14.
Okay.
Okay.
That's a 6 millimeter Mustang?
No, it's a 8 millimeter Mustang.
Okay. Alison, what do you see? If you can go to the microphone. So,
There is a dissection of the wall or a flap on the filling defect on the undersurface
Yeah.
of the RPA.
so what to do now?
I still would be reluctant to stent
Yeah.
the Williams.
Yep. Okay. Yep. Zaid? There's a dissection flap of some sort.
I probably would have done nothing to start with.
Yeah.
But
But
we suggested don't touch the right PA.
yeah.
But I would leave this alone.
Yeah. Okay.
I would definitely not stent. I agree with that.
Yeah. Anybody in the audience would stent now? Anybody? Okay. All right. So Shiva, what presumably you're trying to show is after the Mustang balloon, you've got a dissection flap,
Yeah.
the inferior aspect of that right pulmonary artery.
Yeah.
Yep.
So I heard Zahid telling that basically he will do nothing for the, in general, a William with a bilateral pulmonary artery narrowing. I wanted to know the impression of the entire house. If you are having a near systemic right ventricular pressure, what will be the time at which you want to intervene? You want the RV to fail and then intervene, or you want to, this patient had features of diastolic dysfunction with elevated right atrial pressures of 14 millimeters and elevated right ventricular end diastolic. It was not a failing RV. I want ample superstition. Come to AP.
Yeah, so the feeling here is to now, you've probably done a little bit more than enough, and now don't do anything further with the right pulmonary artery.
Okay. Okay.
Because the dissection flap is there, but I wouldn't do anything with that now.
Okay.
So the next question is really just to balloon the left pulmonary artery.
Yeah.
And you've got a reasonable result already, because your
The RV
RV
pressure is
pressure
low,
is subsystemic, which was systemic before.
Yeah, around 10 less. Yeah. So we will address the left also right now. I want the sheet.
Okay. So can we come back to you
Yeah. Yeah.
in a little while again?
Yeah, sure.
All right. So let's go back to tin. This is good fun, isn't it? To start with. Backwards and forwards. So let's go back to tin, can we?
Hello, Siva.
Hi. So
Shiva, we're back with you.
yeah. So we will now show you deflate. So we are now ballooning the left, and you can
What balloon have you got?
same Mustang. See the hilar left pulmonary. Show that LPA before. Previous. The LPA picture.
Siva?
Yeah. Can you once again? We are trying to get the LPA. Show the previous LPA movie.
Siva, on the echo, I thought.
We don't see any moving pictures yet.
Yeah. Can you show the movie? Just show the movie.
Siva, I remember from the echo that there is a membrane in the LP. Is that the one, or is this the one with the membrane?
Yeah. Actually, it was not a
Of course,
membrane.
it was
I will show you.
unusual.
Next picture. It was not a membrane. I will show you. It was a ostial LPA narrowing. Next picture. No, show the LPA angio. Initially we got an LPA. The next picture. Show the original LPA angiogram. I think it is the fourth. Yeah, correct, same thing. Just freeze it. So you can appreciate, you can see that it is, it's not a membranous narrowing. It was, it was unusual, like osteoproximal, osteoproximal left pulmonary artery.
Okay, so Shiva, you've done a 6 millimeter Mustang balloon now?
8 millimeter, because the hilar pulmonary artery here was 9.
Okay,
so
8 millimeter.
So 8 millimeter. Show the last pleura.
Like now?
What are you seeing the pressures on the monitor?
Yes, we are.
No not much of change. Actually, the RV right now is suprasystemic. So I'll give you an angio now.
Yeah.
Can you see that?
Okay. Yeah.
Freeze it. Yeah. This is a 8 millimeter Mustang given. RV is not coming down.
Okay, so Alison, what to do now? The origin of the LPA is a little bit better, or not?
So, Shek?
I think
or
it's
not.
not better.
No.
Now the RV is suprasystemic,
Yes.
so we have more of a problem perhaps than we started with. Can you stent that one open and leave the RPA alone? This is just not a movable membrane, perhaps.
Mm-hmm.
It's not a membrane.
You said it was a 9 millimeter branch pulmonary artery, so why not go with a bigger balloon?
Shaq, I don't think it's
I don't quite understand why the right ventricular pressure rose to suprasystemic level. Is there any dynamic reason
Show
for
the
that,
last
or
LPA. Show the last LPA again.
anatomical? Because the flap in the right
Last
pulmonary
LPA.
artery
Last
shouldn't be that obstructive to increase the right ventricular pressure that much.
Yeah,
So
just
I
run
don't
that.
understand exactly why the right ventricular pressure is suprasystemic now
And
when
presumably-
and
Don't go to
two-thirds
fixed frame.
systemic
I want
when
movie.
starting the procedure.
Yeah, and presumably the ventilation side is not a problem. CO2 is not increased.
No, actually the blood gases are 202 PO2. The child is on mechanical ventilation.
CO2.
No, CO2 is some 20,
CO2.
25. Yeah, all are normal.
Okay.
The anesthetist is controlling everything intact. You can see some amount of
Mansoor.
dynamicity in the RV pressure. Now the RV pressure is systemic. Come to RAO.
Yeah, I
Mansoor.
think what we've done now, probably we done some part, we improved a little bit the part of the obstruction in both PAs, and I guess
See the
probably
virus
what
coming
can
out.
explain now the high pressure is both sheaths in the right ventricle out of flow tract. It could explain, but in this patient, you can see peripherally there is a multiple branch pulmonary or lobar or segmental branch stenosis. And I guess if we decide to put a stent in the left pulmonary artery, I might do as well for the right, because he will go anyhow each time to dilate the left stent. They can
Show
do
the previous
the right
picture.
stent as well. So we have to finish the job at the same time if possible.
Yeah, I would still try and avoid stenting as much as possible and either work on this with a next size up balloon, maybe 10, and then, but low pressure, and then stop.
Shaq, show the previous LPA, last LPA. the last left pulmonary artery picture. No, the previous. Freeze it. Actually, there is no peripheral pulmonary artery stenosis beyond the hilar LPA. In fact, after the hilum, the whole vessels are looking good.
Okay, well, maybe we're not seeing it very well. There are a few stenoses I can see.
Just go back and forth, go 1 or 2 frames above.
Shiva.
Yep.
So we're just going to go back to tin again and then come back to you whilst you decide what to do.
Okay, now
Okay.
this is the right.
Yeah.
Freeze the right.
All right, go on, let's have a look at the right. Yeah, so I would accept the right. We'll come back to you. Yeah, Shiva?
Yep. Okay, deflate.
Yeah, we're back with you now.
Yeah, I will show the previous picture. Go 2 more before. 2 more before. 2 more before. 2 more before. Before this. Before this. Before this. Yeah, okay. See, Shaq, this was after the 8 millimeter balloon high pressure of both the right and the left. The right ventricular pressure was near systemic. In fact, it was marginally suprasystemic at that time. And the post-hilar left pulmonary artery was having a pressure of 40 with an RV of 90, giving a 50 gradient. And on the right side, it was 20 in the hilum with 90 in the RV, giving a 70 gradient. So what?
Okay.
And then next picture. Okay, show the next picture. I think next was better. Freeze it. No, boss, please. Previous. Yeah, freeze it.
Reception flap is less impressive. It's still there. But.
Yeah, but even though we are having a lumen that is wide open, the gradient was 70 millimeters across this area from the hilum to the right pulmonary artery. So now the issues were there was at that moment the RV was going marginally above the systemic pressure, and you were actually watching that. So what we did was next. So we took a formula 418 816. Next. So this is the final inflation, and now I'm going to withdraw the balloon out and do a check angiogram.
Okay. So this is the formula. Did you say 816?
816. Yeah.
Okay. All right. Let's see angio without the balloon.
Yeah, I'm taking the balloon out. Okay, go to the same RAO, yeah, same picture.
You could do the angio through the left sheath.
Yeah, that's what I'm doing, yeah. Mag on that, zoom, only the right, yeah, come down. There is some little bit of leak from the side arm of the sheath. Right now, what you are observing on the other side, the RV pressure is almost about 50% systemic. Are you able to see the pressure also, Shaq?
Yes.
Yeah, but can you change the red into yellow? Change the red into yellow. I think red is not visible. Okay, fine.
No, yeah, we see it though.
Okay, so right now go back to the left. We will see the left how it is. Shaq, as I was mentioning earlier, the pressure, I will now show you the pressure in the post-hilar LPA. Go to LPA picture. LAO, go to LAO. See, this is the left shack. Can you see that? It's around 30 systolic.
Yep. Okay.
And the RV.
So what are you thinking about the left?
I'll give you another picture. Just have a look at it. Shaq, I think that Williams. I have not had a good result. Zoom it now. I have not had a good result with just plain balloon alone. I'll show you. Freeze that.
Yeah.
Freeze. Just go back. Go back. Shaq, the ostium of that left pulmonary artery is looking less than half the hilar left pulmonary artery.
Yeah, yeah. So now the decision in my mind is easier because you've stented the right. Now I would stent the left.
I think so. I will connect back to the right ventricular pressure.
It's interesting how starting from the general consensus on not stenting at all anything here, we are ending up with stenting everything.
Yeah, but now he's
That's
stented
great.
the right. There's no harm in stenting the left. But yeah, go
Maybe
on.
the Formula 18 doesn't really go to a great dimension. It's like Formula 35 would be a bit more
This
prospect.
8 would go up to about 14 maximum, I think.
Yeah, at a real stretch.
Yeah.
Is Oliver there in the hall? Shaq, is Oliver there in the hall?
No, he's Oliver is in with Tin doing the case. And
Okay.
So we're going to go to Tin now.
No,
then come back to you.
I wanted to make one point on Kevin's point. What Oliver says is the stent is the same in a 418 8 millimeter and a 535 8 millimeter. It is the balloon that varies. And he says that an 8 millimeter formula 418 on an in vitro testing, he has blown it up to 16 with no foreshortening. But actually he has written a paper on that. So that was the reason why I wanted to know whether Oliver is there.
Yeah, no, so Shiva, we'll come back to you. We're just going back to Tin now.
Okay. So what are you seeing, Shaq, with you? See, there's that. Show the previous picture. Show the previous. Yeah. Show the previous. So what we did was we took an 8 into 12 formula 418 and show the previous.
812.
Yeah. Previous. Yeah. I think this is fine. So this is the positioning of the stent. So from this position, this was actually at the ostial and the proximal LPA. So we withdrew a little bit back. Next. Next. Then we adjusted it. Next. 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 Forward. Forward.
No, he's going backwards.
Yeah. Okay. So this is the final. Now next. Next. Yeah. So this is where we are currently. The hemodynamics on the other side, yeah, it's little less than 50%. I will make an. I thought I will just inflate the RPA ostial, the RPA stents ostium a little bit better. What do you feel?
I would not do any more at the moment. I think I would leave things as they are.
Okay. I'll give you one.
Just show the other projection if you could.
Yeah, sure. So
show the other projection.
Can you come to the right RAO projection? This gave a better injection.
And also, you've got a really good response to RV pressure. So
yeah, the RV pressure has come to around 45% of systemic.
Yeah. So I would not do anything else. Yeah, I would leave it. Okay? Yeah. Okay. Shiva, that looks as, it started off as a complex discussion case, and we finished up doing all the things that the audience and experts here didn't want you to do, but you've got a very good result despite our advice. So thank you very much to you and the rest of the team, and we'll come back to you later on.
Yeah, sure, sure.
Yeah? Okay, well done.
Okay.
Big hand to Shiva.